This is Immunology Unit 4, Lecture 7. We'll be covering HIV and AIDS. Here are your objectives. HIV is a virus that attacks the immune system, and when left untreated, it causes AIDS. HIV is a retrovirus. It contains RNA as its nucleic acid, and it contains reverse transcriptase. This transforms RNA into DNA. The structural genes of HIV include GAG, which codes for the precursor proteins that form the core structural proteins embedded in the capsid that surrounds the nucleic acid envelope. POL codes for enzymes necessary for replication, and ENV codes for glycoproteins GP160, GP120, and GP41, which are found in the viral envelope. HIV enters the body through three main routes: sexual, contact with blood or body fluids, or from mother to fetus. So let's go over the role of T helper cells in viral replication. The virus attaches to the CD4 antigen of T helper cells. Chemokine receptors cause conformational change in the envelope protein, allowing the virus to enter the cell wall. Then the viral genome is exposed. Reverse transcriptase copies viral RNA into complementary DNA, and complementary DNA is integrated into the host genome and replicates when the cell divides. These are called provirus, and they can remain latent or be induced into activity. At reproduction, viral DNA is transcribed into messenger RNA and transported to the cytoplasm. Messenger RNA is translated, producing new viral particles that bud from the cell wall. As the virus replicates and buds, the cells are left either dead by lysis or are non-functional. T helper cells play a critical role in regulating activities of B and T lymphocytes, and therefore antibody and cell-mediated immunity is markedly decreased. Susceptibility to opportunistic infections and tumors progress. During the primary infection, there are high levels of virus in the blood and lymph tissues, and that's when the immune response begins. During the secondary stage, it's characterized by latency as the amounts of circulating virus decreases. And in late stage, or AIDS, there is increased viremia with severe immunosuppression. Untreated patients will proceed to AIDS within 10 years. Antibody is detectable within 6 months of infection and remains throughout the course of the disease, only to wane in the final stage due to immunosuppression. So there are a couple different categories. HIV-1, there's the M group, which is the main group. It's classified into subtypes based on the nucleotide sequences. There's subtype B, which is most predominant in the US and Europe, and subtype C, which is most prevalent worldwide. There's also group O and group N. A handful of divergent isolates are present in Africa and Asia. HIV-2 is related but genetically distinct, and it's endemic to West Africa. And HTLV-1 and 2 is human T-cell lymphotrophic virus, also a retrovirus that can cause ATL, tropical spastic paraplegia, and non-Hodgkin's lymphoma. So the diagnostic test we use for HIV is CD4 T-cell enumeration. You should know that the normal range is between 500 and 1300 cells, and less than 200 is consistent with AIDS. Here is the formula to calculate the absolute CD4 count. To detect the antibody, we can use ELISA or the Western blot. HIV ELISA is the first test usually run to rule out infection. It's highly sensitive. This test is reflex to HIV Western blot for confirmation, and this is not a good test to use on infants. Western blot is the confirmation test for HIV infection. The CDC criteria is to report positive if at least 2 out of the following 3 bands are present: P24, GP41, and GP120-160. If some characteristic bands are present but do not meet criteria, the results are considered indeterminate. We can also test for the HIV antigen. P24 is part of the virion core. Levels are high during the initial weeks of infection and the late stages. It's not as sensitive of a screening tool as the ELISA test for the antibody. To detect HIV viremia, we use PCR, branched chain DNA, and NASPA. We also need to monitor HIV drug sensitivity. Since the high mutation rate of the virus results in resistance to the antiviral drugs, genotypic and phenotypic assays are used as an indicator of drug sensitivity. Genotypic assays detect mutations in the reverse transcriptase and protease genes of HIV. Phenotypic assays check the ability of the virus to grow in the presence of antiviral drugs. HIV DNA testing by PCR is used in infants. It gives qualitative results, testing for proviral HIV DNA as the target. The limitations are the sensitivity and specificity, so multiple tests over the course of time is recommended, usually at least twice. That's it for this lecture, and that's all for this unit. Good luck on your tests. Let me know if you have any questions, and of course, don't forget to take the quiz for this lecture. Bye.